All right, thank you for joining today's event on avoiding non-affirmed prior authorizations on botulinum toxin or Botox services. My name is Mary Sue Gardner, and I'm a registered nurse on the Provider Outreach and Education team. And I'm going to be your facilitator for today's event. And I'm also joined by other members of Provider Outreach and Education, as well as medical review, who are going to be helping with the chat portion and the question and answer portion of today's call. My objective for today is that you learn about how to receive affirmed prior authorization decisions for your Botox services that are provided in the hospital outpatient department that require prior authorization. So that's what we're focusing on today. We're focusing on prior authorization and getting those affirmed decisions for your prior auth of Botox. We're going to achieve this objective today by reviewing the most common reasons for non-affirmed decisions, as well as reviewing the documentation that's necessary to support the requirement. And finally, we're going to talk about some upcoming changes in the Botox process. So let's start today's event with our first agenda item of reasons for non-affirmed decisions. Our first reason for non-affirmed decisions has to do with subsequent injections and the reduction in migraines from the last injection. But before I tell you exactly what those reasons are, I'm going to first poll you, my audience, with a knowledge check question. So the poll questions and selection options should appear on the side of your screen. In just a second here, I'm going to launch this poll. So I'm going to verify with Jennifer that you can see the polling question come up, Jennifer, on the side of the screen.
Yes, it's up.
Perfect. So the knowledge check 1, to provide a subsequent injection for migraine, the frequency of total episodes must demonstrate greater than what percentage of reduction on migraines per month? 10%, 25%, 50%, or 75%? And I'm seeing answers come in. And we're going to close that polling now. It looks like answers have slowed down. And the answer is 50% reduction in migraines per month. So the total number of chronic migraine days must be documented that they demonstrated greater than or equal to 50% reduction in headache days per month. And the frequency of total episodes has demonstrated greater than or equal to 50% reduction in migraine episodes per month. So without this information, we cannot affirm the subsequent injection for chronic migraines. So that's our first issue that is causing non-affirmed decision. So as we move on to our next knowledge check, and let me go back to the next one. And we're going to launch this true or false question. A specific scale must be used and submitted to measure disability for migraines. So is there a specific scale that must be used and submitted to measure that disability of migraine? And I see answers coming in, and as it slows down, I will close that. All right, and I'm closing that now. And the answer to that is false. There is no specific scale, but you must provide an objective assessment and it must be performed on the same scale at each visit. So CMS does not govern the form or the scale that you need to use, but you must use the same form consistently for your patient. So you should assess before the injection, after each injection, and at any follow-up visits that you do. When requesting a prior authorization, you need to submit the scale results as well, as those are part of your actual documentation. So as we move on, our next knowledge check. Go ahead and start this poll. And the question to this is yes or no, can a calcitonin gene-related peptide or CGRP be started after Botox injections are started for migraines per the local coverage determination? I'm seeing results coming in. And a few changes in results. Things are starting to slow down a little bit here. And we're going to go ahead and close the polling of that. And the answer to that is actually no. You cannot start the CGRP after Botox, but you can start the Botox after the CGRP. So per LCD, initial Botox injection indications for coverage. So this is in that section, and it's actually numbers 8, 9, and 10 in the indications of coverage. So if the beneficiary is currently using a CGRP agent for chronic migraine prophylaxis and is going to be using the CRGP and Botox together, the following must apply. So we need to see that the beneficiaries had a reduction in the overall number of migraine days or a reduction in the number of severe migraine days per month with the CGRP use, but still has chronic migraines that are going to require additional therapy. And that additional therapy would be the addition of the Botox. And then it goes on to say, and the headaches are causing an objective significant functional disability, and the headaches are moderate to severe in intensity with typical migraine headache characteristics. And it goes on to say that the Botox serotype is one that is approved by the FDA for migraine prophylaxis. So the request for prior authorizations that come in, that request needs to clearly indicate that you want to start the, that if you start, in the wrong order, those requests are not going to be affirmed for this, prior authorization. So remember, the answer is you cannot start a CGRP after Botox, but you can start Botox after CGRP. So again, that's one of the reasons that we have been non-affirming some of those decisions. All right, I get tongue-tied with all the acronyms. Let's move on to the next poll, or next knowledge check. Which diagnoses are currently included in the prior authorization request for botulinum toxin or Botox services in the hospital outpatient department? Ooh, hang on, my session. Launch this next one. There we go. Forgot to turn that on. So which diagnosis? The 64612 and 64615, the 12 and 16, the 15 and 17, or all the codes that are listed in the billing and coding article. All right, so we have stuff coming in. And still a few questions being answered here. Okay. And it looks like things have slowed down. So I'm going to close this poll and we'll go to the answer. The answer is number 1, the 64612 and 64615. So those codes must be appropriately paired with one of the listed injection codes to be considered for prior authorization request. So currently, any combination that is not the 64612 or 64615 with one of these listed J codes here and identified on this, those do not require prior authorization. So the prior authorization request process is only for those services provided on a 13X type of bill, hospital outpatient department, that are the 64612 or 15 paired with one of these G codes. If that doesn't exist and it's not provided in the hospital outpatient department, billed on a 13X type of bill to Part A Medicare, then it's not something that requires prior authorization. So this is an issue that comes in quite frequently that we want you to know about. If your service doesn't require prior authorization, don't submit that to us. It's just a waste of your time and energy. It's a waste of our time and energy. We have to open the request and look at the information and make a review only to say we're not going to affirm it because it's not one that falls into the types that are requested. All right. So we'll close that. Oops. Voting is closed. Okay. And then our 5th issue and our 5th knowledge check that is on the list is which botulinum toxin uses are not included in the hospital outpatient department prior authorization process. Oops, did I launch the wrong poll? It looks like I may have launched the wrong poll. So sorry about that. All right. Now the correct poll should be launched. Sorry about that. And I see answers coming in. See a few answers changing. And this is mark all correct answers. So mark multiple answers on this one. A few people are still changing their mind. All right, it looks like we are coming to an end with the voting. Things are slowing down, so I'm going to close that poll. And the correct answer to this were both number 1, the interstitial cystitis and bladder syndrome, and number 4, hyperhidrosis. Those diagnoses are not part of the prior authorization request process for the hospital outpatient department. What is part of the prior authorization process includes migraines, blepharospasm, Maze syndrome, which also includes blepharospasms with oral facial dystonia and hemifacial spasms. So you're going to want to refer to the billing and coding article that's linked at the bottom of this slide. Remember to check your code combinations as well. Any code combination that doesn't match the ones that are currently listed for the prior authorization in that HOPD or hospital outpatient department do not require a prior authorization request. So remember that. those code combinations don't match, they don't require that hospital outpatient department request. Okay, now that doesn't mean that you do not need to follow all of the billing coding rules as well as any LCD indications that are listed if you're going to perform the service. It only means that that doesn't require a prior authorization request. So once again, to reiterate all of this, there are specific administration codes and injection codes that when provided in the HOPD require a prior authorization request. So these must also be allowable for the diagnoses that the patient, requires the Botox for. So it's the responsibility of the provider to check the diagnosis versus the indications of coverage versus the place of service and determine if the service actually requires prior authorization. All right. So that is the end of my polling questions. I'm just moving stuff around on my other slide here or other screen here. And we're going to move on with documentation and what's needed for your prior authorization request. The first thing is an approved diagnosis per our billing and coding article that you can link to from this slide. I've got a direct link here. Once we get you that slide deck, you can use that. Like we spoke about earlier, there's certain diagnoses that fit with the injection codes and the pharmaceutical codes listed. And you can refer back to slide 13 later to see those diagnoses. So the diagnosis needs to be contained within your documentation and not just on the bill. We actually need to see within your documentation what the physician has diagnosed that person as having. Other pieces of documentation include your history and physical, progress notes that also are going to help support the diagnosis. They're going to give any kind of pertinent history on your patient, any kind of background on their condition. Those are the things that we pull out of your H&P and your progress notes. Other things, the site of the Botox injection. Where do you plan or where does your physician plan to inject the Botox at? We're going to look for units of Botox to be administered. And then units administered during past injections. So if you're doing secondary injections, et cetera, we'll want to know that information about past injections. So this is going to include any waste as well. Additionally, we need to see that the Botox type because only certain types are allowable and require prior authorization if they're paired with the 64612 or 64615 injection codes. Again, you can find these codes on our website and back just a few slides before I've listed those codes as well. Finally, the last general piece of documentation that we're going to look for is the duration between injections. And if there has been a documented allowable time, like the 12 weeks between, unless it's otherwise stated that it can be done earlier. Generally 12 weeks in between, again, for the prior authorization services. But if it can be done earlier, we're going to look for that time frame. Now, let's move on and talk about some specifics for the different type of Botox services that fall under prior authorization. Starting off with blepharospasm. When it comes to the initial injection for blepharospasm, the first thing that we need to see and verify in your documentation is the type of Botox used. So listed here on the screen are the improved types for the blepharospasm. As listed in our LCD, the objective clinical features that you need to make sure are documented include things like involuntary forceful eyelid blinking, squeezing that's progressing to difficulty keeping the eyes open, and even up to functional vision loss and bright light, wind, or with fatigue. We're going to look for proof of chronic blepharospasm, which has been occurring at least 30 days prior to the Botox injection. So it would be considered chronic if it's been going on for at least 30 days prior. And it's measured on an objective clinical scale. And we need that to measure the severity and the impact to the patient. So when it comes to subsequent injections for the blepharospasm, the types of Botox remain the same. The initial dose was 1.25 to 2.5 units per approved injection site. And so the sites include the upper lid, medial and lateral, pretarsal, orbicularis oculi. I'm going to be tongue-tied today, so some of these words we're just going to skip if I can. They are printed on the slide for you. Anyways, additionally, there needs to be documentation of informed clinical decision-making. So the beneficiary has to agree to additional or repeat injections. And that's your informed consent. As well as the blepharospasms are measured on an objective clinical scale. So again, we're looking for severity and impact. So that would be the same scale you used at baseline. And then proof in your documentation that supports the persistence or reoccurrence of moderate to severe blepharospasm. So some of those scales include the JRS or the BSDI. Those are not the only ones, but those are some that are included. So a little bit more on subsequent injections. If the first injection lasted less than 8 weeks, the dose can be increased up to 5 total units per site. Or if the treatment lasted 12 weeks or greater, it is not expected to increase the dose. So we wouldn't want to see that if there was, good outcome and it lasted for 12 weeks. All right, so as we move on with the blepharospasms associated with the orofacial dystonia or the MASH syndrome. So initial injections here. The documentation for the initial injection includes the approved injectants that are listed here with no standard dosing. Additionally, the documentation identifies those clinical features of the blepharospasm. And again, we've already included, the involuntary, forceful eyelid blinking, squeezing, the progression, etc. We included that on the prior slide. So chronic, moderate to severe blepharospasm associated with the orofacial dystonia documentation, it also includes objective clinical scales. Again, I'm going to say this a lot today. Those scales need to be done at baseline and after each injection. And you need to use the same scale each time. Other documentation includes the units to be injected. And we'd want to see that on the prior authorization form as well. All right, as we move on in the subsequent injections, so the documentation for the subsequent injections includes, again, your continued informed consent by your patient that they agree to continuation of having these injections. The chronic moderate to severe blepharospasms with orofacial dystonia are documented again on that objective scale, baseline, et cetera, et cetera. If that injection wears off prior to 8 weeks, an increased dose can be given, but this again would need to be clearly documented as well. So as we move on, cervical dystonia or spasmodic torticollis is our next service. Again, the improved injectants are listed here at the top of the slide. You got to have improved in your documentation that you have the diagnosis of cervical dystonia. Additionally, documentation must also identify the etiology of the CNS or central nervous system impairment that is causing the cervical dystonia, as well as documentation must identify that the beneficiary has a history of recurrent clonic or tonic contractions of one or more of the following muscles. And so we've got those listed here: the sternoclinoid mastoid, the splenius, trapezius, or posterior cervical muscle. So as we move on with the indications, additional documentation. Again, there needs to be moderate to severe CD assessments done on an objective scale. And again, I'm not going to beat it to death, but do those at baseline after each procedure, any follow-ups, etc. So some of the clinical scales here is the TUSI, I'm sure I'm going to pronounce these wrong. It's the TSUI score and the Toronto Western Spasmodic Torticollis rating, or TWS. TRS. Those are the few of the scales that we typically see here. The documentation, again, objective measurements of abnormal posturing with limited range of motion in the neck or sustained head tilt. So we're going to look for that in your documentation. And the documentation supports the duration that the CD has been at least greater than 6 months. The initial dose is based on the patient's head and neck position. So we're going to want to look at that. We're going to want to have indications of that. We want to see the localization of the pain, the muscle hypertrophy, and the patient's response. And then again, any adverse event history. So use the lower of the initial dose in the botulinum toxin patients. I'm sorry, I just got distracted on something that popped up on my screen. And then finally, your objective measurements at baseline and after each injection. All right, so the dosing guidelines. So this slide contains the dosing guidelines for the initial and subsequent dosing, including the types and units. The important thing to note is that you must document the type and number of units that you provide. And if you are wasting any units, that you also keep documentation of that as well. So again, under your initial diagnosing, initial dosing, the types and the amounts, and then we move on to subsequent, which would also include the types and amounts that are allowable. So I'm not going to go over each of those specifically. You can look at those, yourself. And this is also listed in the current LCD. All right. So additional documentation again includes evidence that the beneficiary is requesting and has agreed to subsequent injections. So your informed consent. What we want to see with any type of initial injection, and I really need to stress this a lot, is the response to the initial treatment, that is documented and kept within your medical records. So objective assessment, again, is performed and you're using that same scale, and that's part of it. But again, what's the patient's subjective information? How did they feel? How did they respond, etc.? And then take that subjective information and make it objective and quantifiable. The patient says, I got good pain relief. Quantify that with, okay, you reported your pain was 8 out of 10 prior, and now your report, or what is your, scale? How long, how many weeks, how many days, how many, etc. What percentage of disability do you think you're improved upon? So again, use that patient's subjective information, turn it into quantifiable, objective, and measurable information, and make sure you are keeping documentation so you can help support the need for subsequent injections of any type. All right. And then migraines. Let's move on to migraines, which is one of our biggest prior authorization review categories. So things that we're going to want to see in your documentation, including things like your migraine features. Do they have any associated sensitivity to lights or sounds or smells? Is it causing any kind of nausea or vomiting? Is there a worsening of the migraines with any kind of slight physical exertion, such as bending over or walking or going to the bathroom? Does this happen to make things worse? If all your documentation is just supporting the diagnosis of a headache alone and not a migraine, you could possibly be looking at non-affirmed decisions. So make sure you are supporting those migraine features within your documentation. As we move on and discuss chronic migraines in the documentation, you're going to see this goes from 1 of 4. So the next 4 slides really are going to discuss the documentation for chronic migraine. So again, identify the type of Botox being used and make sure it matches the types allowable for migraine use. We're going to want you to document the monthly headache days, and that we've got it greater than or equal to at least 15 headache days per month. And monthly migraine headache days have occurred with greater than or equal to 8 migraine days per month, and that the migraine headaches are documented to be lasting for a duration of greater than 4 hours on their migraine day. And then as we move on, chronic headaches have been present for a period of at least 3 months. So again, in your history gathering, how long has this been going on? A 2-month trial of at least 1 agent and 2 classes of medication at that target dose was completed and not effective. So if there's intolerance to these drugs that cause you to do something different, we need to see that as well. And those classes include things like antidepressant classes, which is your amitriptyline and venlafaxine and nortriptyline and duloxetine. And then your beta blocker class, metoprolol, propranolol, atenolol, etc., all those lols, calcium channel blockers, and then the anti-epileptic classes. Those are some of the most frequent. One of the most frequent we see is the gabapentin use in that class as well. Continuing on with the migraines, to reiterate from the last slide, so your documentation again must include 2-month trial of these agents at their target dose of the usual dose, or if there's an intolerance to the 2 agents in each class, and if they're currently using a CGRP for the chronic prophylaxis, and they're going to be using the CGRP and the Botox together, that there is a documented reduction in the overall number of migraine days or chronic migraines that are going to require additional therapy, like adding Botox if you were using the CGRP. So adding Botox for prevention. As we discussed way back at the start of this presentation, make sure if you're going to be using both that the CGRP was initiated first. All right, continuing on under migraine documentation, under the initial injection, the documentation, we want to see that the headaches are causing objective significant functional disability on your disability scale. And that's got to be, again, documented at baseline and with each injection. That we need to see that the headaches are moderate to severe in intensity at baseline with typical migraine headache characteristics. And we've discussed those as well as the fact that you're using a serotype that is approved by the FDA for chronic migraine prophylaxis. And we discussed those types as well. All right, some of the initial dosing guidelines when it comes to migraines. So this screen contains those dosing guidelines for the initial dosing on migraines. And the initial dose is 155 units given as 5 units per each site divided across 7 head and neck muscles. And those muscles are included here as well. All right, when it comes to the subsequent injection, the documentation must include the total number of chronic migraine headache days have demonstrated greater to or equal than a 50% reduction in migraine headache days per month, and the frequency of total episodes has demonstrated greater than or equal to a 50% reduction in migraine episodes per month. And those changes in headache-related disability and objective overall improvements have been made. And as we continue on the next slide, the biobehavioral therapy has been assessed and implemented as appropriate for preventive and acute headache treatment. So biobehavioral therapy includes cognitive behavioral therapy, any kind of biofeedback, any kind of relaxation therapies, mindful-based therapies, and acceptance and commitment therapy. And if you're using concurrently, again, with the CGRP agent for prophylaxis, that the beneficiary has had a further reduction in that overall number of migraine days or a reduction in the number of severe migraine days per month compared to a monotherapy. And again, got to have approved serotype. All right. So the dosing for chronic migraine subsequent is a dose range between 155 and 195 units. So again, 5 units per each site divided across 7 head neck muscles that are listed on the prior slide as well. And then when increasing to 195 total units, the additional 40 units to be administered with the follow the pain strategy. So we're going to be looking for the fact that you are following the pain using that strategy when you are increasing to 195 units. More than 195, we're just not going to allow. All right, next one is the hemifacial spasm and facial dystonia. All right, the initial injection documentation requirements for this group includes the approved type, which again is listed here, And this is acceptable as first-line treatment for both primary and secondary. So the Botulinum Toxin A, that's a mouthful. And I don't want to say that word much because it's such a mouthful. All right, so you have their approved type and that objective documentation of the clinical features that are consistent with the diagnosis of primary or secondary hemifacial spasm, or HFS. Moderate to severe primary or secondary HFS is measured again on your objective clinical scale, because we want to see the severity, complexity, and any kind of psychosocial aspects of the hemifacial spasm or the HFS. So again, do those at the approved times, at baseline, after each injection, any kind of follow-up visits, etc. And provide those scales to us. That's no different than any other type of injection, requirement. Dosing guidelines are listed here, and the total dose is 25 to 30 units on the initial dosing for the hemifacial spasm. Subsequent, when it comes to the subsequent injections, we're going to look for documentation again of that informed clinical decision making regarding the need for a repeat injection, as well as the reassessment of the degree of persistent moderate to severe hemifacial spasm. So again, we're going to look at your objective assessments that you perform, and you do those objective assessments every time you see the patient. We're going to look at documentation from your follow-up appointments to see this. We're also going to need to see that there's proof that there's been at least 12 weeks since the last injection. The subsequent dosing guidelines for HFS include a gradual increase in the number of units, and that usually is 5 to 15 additional units. After 1 year, those may be required. All right. So as we start to wrap up, let's discuss what's on the horizon for prior authorization of Botox services. First, I want to let you know, in the proposed final rule, there are additional Botox codes that are going to be added for prior authorization requests starting in July of 2027. So this has come about because CMS really continues to chase the data in these reviews. And they've seen an average annual growth of these codes of 4.6%. The claim volume of these codes has increased from 43,500 in 2017 to approximately 62,100 that were submitted for payment in 2024 that included these codes. So you can find these 8 additional codes in the Federal Register proposed final rule that's linked to on this slide. And let me take a peek at the time just to make sure we stay on target. I'm going to link out to this federal rule and show you really quick and have you, or Federal Register, I'm sorry, proposed rule. And I'm going to open the PDF version. And if you go to page 244, that is going to take you to table 76. That's going to give you the table listing of these proposed additional codes. So you need to be on the lookout. We need to watch final rule. You can read through this proposal, get an idea, get the data behind why these additional codes were added, but it comes down to the fact that once prior authorization of the codes that we currently have in effect went into effect, and we started seeing the overall usage of those codes go down, the usage of these codes then started to go up. So CMS has done the data, done the research, identified the next set of codes that are most often seen in the hospital outpatient department, and they're going to add these to the list that require prior authorization in July of 2027 for prior authorization reviews. I'm gonna jump back, but that is the reason why, and that's where you can find that. And I put that link right here. So after this presentation is done, when I send you the presentation, you'll have the direct link. Sometimes it's really hard to find the federal registers, proposed rules, final rules, etc. if you're just looking for them on your own. So it's nice to have a link to that. All right. So as most of you know, the LCD for this event went back into draft comments. So it went into this consideration period because the nation as a whole offered a lot of great input to what's currently out there that really required a relook. So since this is a multi-MAC LCD, that means each MAC needs to go through the process of accepting comments and evidence-based literature to support any requested changes that they want, that providers, associations wanted to see to the LCD. So all MACs are currently in that process of re-looking and looking at those changes. So in our LCD, there is a synopsis of changes that have happened. So I have a link to the draft LCD that I'm going to link to right now. And I'm going to show you where to find this. And we're going to go to the draft. This is what's currently proposed. And I am going to actually just quickly go down to synopsis. It's just easier. It's easier for me to search. Oh, I don't know why that did that. Let's close that. Let me do a control find again. Did I spell that wrong? SINOPSIS. Well, usually it'll take me to. We'll go the hard way, and we'll scroll down to the bottom. I don't know why it originally took me there and then it took me back out, but here is where I want you as a provider to pay attention to the LCDs. When we make changes, there is a synopsis of change that is associated with each of our LCDs. And I don't know why it's not going there. We're gonna do this really quick. We're gonna try this link again. And we are going to go back into the draft. And there we go. Good gravy. There we go. And the synopsis is over here and the quick links as well, which I, for some reason, totally forgot about. Okay, so in the synopsis of changes, this is where you're going to find what is going to be in the LCD once it goes final. So once the LCD is in effect status, meaning it is final but not yet effective until the date that's listed on the LCD as the effective date, here's where you're going to find all those changes. Remember, some of the changes could affect the prior authorization process, and some are only going to affect Botox services that don't require prior authorization. What I'm showing you right now is the last set of changes that were made to the current effective LCD. So this area will contain more information about the next changes. Since the formal comment period has ended, we're now in the process that those comments are now being considered. So any additional changes, again, once this turns from proposed to final, that's where you're going to see the changes that may possibly affect where you are providing Botox services or what types of Botox services that you are providing. It usually stays in that final effective period for a while before the effective date hits. So for right now, you would want to make sure that you are using the LCD that is currently in effect. I am in the draft LCD right now, but you're going to want to make sure that you are using the current effective LCD. All right. So again, this area is going to contain more changes since it's back out in the comment period. I was hoping to know more at this time about when that will be done, but unfortunately I don't. Just due to the sheer volume of comments that all MACs receive. Remember, I said this is a multi-MAC LCD. So each of those MACs needs to take the comments that were submitted by their providers into consideration. And then they have to get together all the MACs and then make the final determinations on what's going to change based on the comments that have come in. And then it will, once all the MACs agree, then it will go back out into a final, then a final effective LCD. All right. But that's where I wanted you to be aware, you know, that's where you're going to see things. We're going to advertise the minute it is done and goes out in the final. That will go out with our policy emails. So if you're not already subscribed to our email list, I do encourage you to get on those and subscribe to those emails. All right. And then finally, some resources on prior authorization and overall prior authorization for any HOPD services, where you can find request forms about the LCD. You can link to the LCD that's currently in effect. You can link to the billing and coding article that's currently in effect. And again, any CMS resources that's going to take you to the benefit policy manual and talk about, you know, the general exclusions from coverage. Obviously, if Botox is being provided as a cosmetic service, it's not going to be covered under Medicare. And let's recap. We've still got some time, and I'm going to turn it over to Candy in just a little bit. And she's going to go through some of the pre-submitted questions and answers and some questions that have come in through the chat that she has probably already answered. But to recap, we went over a lot today. We learned about how to receive affirmed prior authorizations for Botox. And we did that by reviewing first the reasons we don't affirm and what those common reasons are, so you can make those corrections if you need to within your facility. We discussed that documentation. So if you're not getting something based on documentation not being submitted, then you've gone through and you've learned about what documentation actually is required. And then we finished with reviewing some of those upcoming changes, not only to the LCD, but also those changes that are coming out from the proposed final rule. So at this time, oh, before I turn it over to Candy, I just wanted to give you a little bit of information before we move to the Q&A about an opportunity to attend the National Provider Enrollment Conference that's hosted by CMS. So CMS, in collaboration with the DME National Provider Enrollment East Group contractor, they're going to host this National Provider Enrollment event, and that's November 18th and 19th in Orlando, Florida. Now, the purpose of this conference is to educate providers and supplier community on multiple aspects of provider enrollment. So these events represent the largest gathering of providers and suppliers and allows CMS the opportunity to really address a large, diverse group and really enhance our provider enrollment efforts. So CMS, the MAC, NPE staff, they're all going to be responsible for co-presenting on topics. And CMS is going to coordinate with the contractors on these sessions. Registration is going to open next month, and we will have a link to register listed on our website as well. So if you want to spend a couple days in Orlando, I highly recommend that, especially if you're from one of our Midwest states, that it would be way warmer in Orlando, Florida in November. All right. So at this time, I'm going to ask Candy to come on, and she's going to review some of those pre-submitted questions and questions that we have received in the chat that she thinks warrant telling everyone about. So Candy?
Trying to get myself off of mute, but yes. And some questions are coming in that I think there's a couple that I didn't answer in there, but hopefully we can hit on them right away. But I will go over some of the pre-submitted questions that did come in. So one of these, and Mary Sue did touch on this with her poll she took in the beginning. One of them is, when does the HIT 6 form need to be gathered? Again, with the scales or form that you use, as long as you use a scale that's appropriate for what you're giving the Botox for, and you use the same scale each time, we don't dictate which scale you have to use. We would not deny for using a HIT 6 scale versus another one, as long as we have the information. Okay, as long as the same one's used each time. Let's see. There is one in here I want to touch on. My staff actually make these calls. There is one that says non-affirmations, even though you feel the documentation, it was there, and maybe the nurse reviewer might have missed something, and you feel you sent it over. When the senior nurse analysts call you for a non-affirm, they call everybody for non-affirmations. So something that was non-affirmed today, you'll get the call tomorrow. So it's just that one day behind. Then that would be the time that if you feel something was submitted and it just wasn't caught, please discuss that with them on the telephone call. That's some of the reasons that they make these phone calls. They actually make the phone calls to help you and educate you, as that is part of what we have to do for CMS. So you can, and many of you probably know many of the seniors. So yes, please take that call then. And if you feel something is there, they will take a peek at it quick if you think that you submitted it. Okay. We seem to always get this question. It's about appeals. So you cannot appeal a prior auth, okay? There's nothing to appeal because you didn't bill it yet. And since CMS set up the rule when they started prior auth for Botox, that you can submit for a prior auth as many times as you want. There's no limit to that. So many times what we see happen is if you get a non-affirmation, the seniors call you, they help you, educate you of what was missed in the doc or what is needed that you might have to pull out of a chart, you resubmit, and then a lot of times, most of you are very successful at getting an affirmation then. Let's see, what else do we got, Mary Sue? Somewhere about CGRPs, Mary Sue did touch on that. What else do we got that? Let's see. There is one that's kind of, we get the question all the time, why people that have been getting Botox for 15 years now all of a sudden don't get approved and they were before. Well, that is because the LCD changed February 22nd. The requirements got much tighter, I would say, to an extent. A lot of people, all they had to do was, start filling out a scale and they were good. But that is why, too, Mary Sue will send you the links for all of that information. And it's all covered in the LCD, what needs to be done, okay? There is a specific section for migraines, a specific section for most of this stuff that we prior auth, okay? If there's not a specific section on the top of the LCD, you would just follow that criteria. But it tells you the documentation and everything that you would need, okay? But it is not just one person or one provider that got a lot of non-affirmations. The LCD changed drastically. So big changes, yeah. We kind of expected that would happen, and we'll continue to do education and make those phone calls. Let's see. Should I go over to?
Hey, Candy, as you're looking through some of those pre-submitted questions, there's one question that had routinely comes up that I want to address, and I think it was pre-submitted as well as came in through a chat question, but it's about submitting, who submits prior authorization. And I just want to briefly go through the process really quick again. This prior authorization process is only for those codes that we discussed when they're billed on a 13X type of bill in a hospital outpatient department. So it's the responsibility of the hospital, because what we are prior authorizing is that service is performed in the hospital and that we are giving the hospital approval to bill and perform the surgery. We're not prior authorizing the physician. So if you are a physician's office, you can submit on behalf of the hospital, but you have to have all the hospital information. So their PTAN, their NPI, their codes they're going to use, the codes they're going to submit, et cetera, et cetera. Physician offices do not need that unique tracking number for their bill. It's not required. Similarly, if you are a critical access hospital or an ambulatory surgery center or any other place of service that bills on any other bill type other than a 13X, at this time, those services are not required to be prior authorized. So again, we ask that if you're not in the right place of service and you're not using the required coding combinations in the hospital outpatient department that require prior authorization, that you don't just submit that, because it really is a waste of your time and it is a waste of our time. So with that, I'll turn things back over to Candy.
Okay, I have a couple of them in here that essentially it has to do with needing a prior auth at every injection. At this time, we do need a prior auth at every injection appointment. So every time they're coming in, if it's a covered diagnosis, that would go under 64612 or 64615 every time it gets injected. There was a question about Botox is given generally, you can give it every 3 months, every 90 days. But the prior auths all go out 120 days. And that is just the nature of it. Everything we prior auth, not just Botox, there's auths for other services as well. That is just a set standard that we have from CMS. Every auth is good for that 4 months. It probably works out well, because a lot of people, if they have to cancel an appointment, then you'd have an extra 30 days at least on there that you could still use that UTN. But you could only use the UTN one time. All right. I'm looking through some more that came in, Mary Sue. We have in here, this is a good question. We are not looking for a specific score on the scale that you use. A lot of people will say, well, what does the score have to be? Some of the scales that providers use, they don't even calculate a score. There is no score. It's more of a true or false, a yes or no. There's so many different types that we're not really looking at a score. All right. It's more that the providers are assessing each time kind of what's going on. If that helps. Hopefully I answered. Michelle had a question in here, and that is one. Oh, Mary Sue, and maybe you have this up somewhere. This one, and we always get questions about critical access hospitals, okay? What's the other one? There's another one we always get a question about. This question, though, says, is there a place on the website that shows that critical access hospitals do not need a prior auth for these services? Do you have that site up, Mary Sue?
Well, we don't really identify that critical access hospitals are not included, but what is on the website is the fact that this is only pertinent to the 13X type of bill. So this is only pertinent to the hospital outpatient department when provided in the 13X type of bill.
Yeah, so they don't
but it doesn't, again, it doesn't specifically say no critical access, you aren't included, because your outpatient bill would be an 85X type of bill.
The other one, I just thought of it, is ambulatory surgical centers. We get that question as well. They do not need a prior auth this time either.
I believe those are 72X, and I could be wrong with that. 71, 72. But either way, if it's not a 13X type of bill, it doesn't require. Candy, there was a good question in the chat that maybe you would like to go over again, and it was about historical Botox patients that have been getting Botox for years, and then so they don't really have an initial scale that was used, and you did answer that specific questioner about the injection, and once the Botox LCD changes were made, to use that dating information, the first injection after that. Could you kind of go over that again? I think that's a good question
Absolutely.
for everyone to hear.
Yeah, and we still get this question pretty frequently, but I'm going to give you a scenario so it's a little bit easier just to sort out, I guess, and think of it easier. So let's say I was getting Botox injections for migraines for the last 10 years. Everything went along good. It's working well, meet all the requirements. And all of a sudden, February 22nd, that LCD was updated and it says we need a scale now. You do not need to go back in your documentation and fix the last 11 years or make any kind of special note about the last 11 years. What you do have to do is when you submit for a prior auth, the date after the first time after February 22nd is the easiest way to explain it. So let's say my next injection wasn't until April. When you submit your prior auth in April, you should have a scale in there. Essentially what that is we're going to use that for a baseline, okay? This was a question that I actually brought up to the work group because we didn't know how we would really handle that. CMS also did agree to that. So that will be your new baseline. Most everybody should be beyond that at this time. And because if you think of, let's say the last injection that I got was February 21st, then if it's 3 months later, March, April, May. So the last time or the first time, like that should be over with, unless you have patients that have been longer than 3 months. But yes, do not go back in charting. You just start a baseline and then each prior auth after that, you fill out the same scale and send that scale and your previous baseline one. So the most you should have to send with your documentation is 2 scales, unless you have a patient that's coming back in between all the time. But please don't have them come in to the office so they can do a scale. We did have that happening. They do not have to come back if everything is fine, and they can just go to their next appointment. Hopefully that helps with that part. I'm looking through some more here. More popped in my section. The CGRPs you talked about, Mary Sue. Documentation requirements, that always comes up. If there's a place where you can see the documentation requirements, on our site, there's actually, they are all listed out. And I do believe that's a link Mary Sue sends you. It's by the same area that you would look for the trainings or the encore presentations. Do you send them that link, Mary Sue?
Right after the presentation is done, I will send out the slide deck. And if I get it into YouTube before I send the slide deck out, which probably isn't likely, but I could send the direct link. But otherwise, if you just go to our YouTube page, you'll be able to find the recording of this presentation probably by tomorrow. I'm gonna say tomorrow afternoon. And it'll be under like the Encore playlist. It'd be the easiest place to find it. But it should be up and ready for you to look at again or share with other people by tomorrow afternoon.
Perfect. A lot of these pretty much we covered. A lot of them are for documentation, office visits, stuff like that. Let's see. She went over, there'll be additional CPT codes. That is not until 2027. Oh, this is a good one. We actually had one like this, that we were trying to kind of figure out what was going on our end too. So let's say that you got an authorization, a prior auth for, you got your approval on February 21st, one day before the LCD changed. I know providers are worried that because that LCD changed that we were gonna take back that prior auth, okay? Because it would go out that 120 days. That is okay. We won't take that back. You submitted before the LCD change. You got the approval before the LCD change, and you still get that 120 days, okay? So you can use that UTN. It doesn't, the payment system wouldn't see like an LCD change, if you will, a date, as long as there is an approved prior auth in there. All right. I think another question just came in here, Mary Sue.
I do see that there's a couple of them. One that I wanted to address, and then one that I'm going to throw over to you.
Okay.
And the one that I wanted to address was basically, do we anticipate doing another education once the LCD goes final? Yes. Right now, we're just focusing on the prior authorization and trying to get to you the information on the prior authorization, because that is, for those of you who the prior authorization process is pertinent for, you know, those, we want to make sure that you know that information, you know, as soon as you can. So you can get that prior authorization request in a timely manner. So you have that 120 days to perform and bill that service, etc. I don't have information, unfortunately, right now of when that is going to be final effective, when those changes will be done, but we will blast that out to you, blast that out to like everyone that is enrolled in our listserv. So watch that, watch for it to be listed as final effective, and then we will provide some additional education. And we may need to do it in several parts because it's such a big LCD. So we may need to take and break it down by service. So we're not keeping you all day on an event. So you may see us doing, you know, a couple of different uses of Botox together just to make those more pertinent. And then a question for you that came in, Candy, that I see is, how long does the 50% reduction on migraines need to last in order for approval? And if they have 50% reduction, on the next note, it says that they are only getting 4 migraines, would that lead to a denial? And I think, and that question came in from Shannon. I don't know if you want to
Yes.
pull that up and look at it on your end.
Yeah, I was going to answer that when it was flipped over to me, so we can discuss it because a lot of people do have this question always. So generally, if anybody remembers the requirements kind of before this, a good place to go look would be where Mary Sue showed you the changes. But that 50%, okay, that 50%, especially like when it comes to migraines, okay, it is from, we're going to go back to my scenario. 11 years ago, I went to the doctor's office and I was having 20 migraines a month and 30 headache days. Okay. So what we look at is, you know, is essentially that's still effective. Are you only getting 2 migraines a month now? It's compared to that original, your migraine days. Okay. So it's not per se month or every 3 months, every visit, you know, to each other. You start out with a baseline of, let's say I had 20 migraines a month, and now all these years later, I hardly get any. Well, I probably have about a 90% effective. Okay. When sometimes we're missing just little pieces of information, but if there's enough information there that we could calculate out a number to make sure it's 50%, stuff like that, we will. But most of these are established patients. We don't see tons and tons and tons of new ones every day, just starting Botox. So a lot of these are long-standing patients. So when you put on there, hey, they've only had 2 migraines in the last month, no headache days. Yeah, much better. It's working. Because the starting point, remember, was so many migraine days a month and so many headache days a month. Okay. I hope that really helps explaining it that way, because we are not comparing the scale that we considered a baseline, because we had to start somewhere, to the next scale. Okay. Hopefully
Perfect.
that helps.
So, yeah, Candy, that's going to probably take us right up to the last question that I want to ask, and you may or may not know this answer, and then I'm going to proceed on with closing remarks, because it looks like our chat has slowed down. But do you by any chance happen to know the percentage of affirmations now that you are giving for the 64612 and 64615? Like, if you know any idea of those percentage rates from the implementation of the LCD?
I do think now we're getting close, like 75% are affirmed. It goes up and down quite often. So each month it seems to be getting much better. So hopefully it does stay that way. A lot of times it's something is just inadvertently not sent in, for the non-affirmation, or some just small charting thing.
Right. Yeah. Yeah.
Getting
So
better
yeah,
every
it
month.
is getting better. Oops, sorry. Go ahead, Candy.
I said it is getting better every month, even though the providers sometimes probably don't feel like it, but it is. It really is.
Well, and one of the things is this is a huge number of claims that we do prior authorization reviews for are on this service. So while those percentages may seem like they don't make sense to you as a provider, as a whole, when we look at all of our jurisdictions and all of the prior authorization reviews that Candy's department is doing on just the Botox service, we are seeing an overall improvement. And that's why we want to continue to bring you this information about, what we're expecting, what we need to see, any changes to the LCD, what we, hope to see going forward. So in the interest of time, since we only have a few minutes left, I am going to take things back over and give some closing remarks. I'll ask Candy to take a look at any outstanding questions that are listed in the chat. And if you can answer those online, great. If not, we will take those offline afterwards and send those answers up. But again, I don't want to run over time for anyone. So again, we value your opinion. We want to hear from you on how we did on this event and if it was valuable for you. So the survey for this event only takes a few minutes to complete, and that's why I want to give you the opportunity to do it now. Jennifer's going to place a link to the survey in the chat, and you can go ahead and use that direct link. Otherwise, when you close out of this webinar, a page is going to pop up that looks like this. And it's going to just tell you, you're being redirected to the survey. So it'll have something like CMS Qualtrics in that line. And that's how you know it's going to the CMS survey. one thing I do want you to know, it's a two-part survey. So it's going to get to a point where it says, do you want to continue to give us information? I highly encourage you to do the second part of that, because that's where you get the opportunity to tell us what additional education you need. So again, I encourage you to take the survey and then to take both parts of the survey and tell us what else you want, so we can consider, providing the education that is helpful for you. All right, finally, if you think of any questions regarding this event, you can email those questions to us for the next 10 days. And those will go to, I'll give you the email address, but I'll have Jennifer drop it in the chat again for you. It's wps.gha.education@wpsic.com. And again, send those to us within the next 10 days. Don't send us any PHI or PII. We don't want you or us to get in trouble for that. And remember, we don't have access to claims processing systems. So if you need to find out about a specific claim or the processing of that claim, those questions unfortunately have to go back to customer service so they can look up your information. Remember to, I'm going to send that slide deck here in a few minutes, and to check the notes in that slide deck for any additional information regarding this event. And then again, we'll have the email address and all of that information contained within there. So on behalf of myself and Jennifer and Candy, all of Medical Review and all of Provider Outreach and Education, we want to thank you for your participation in today's event. This concludes our webinar, and you may now disconnect.